Hello, my name is Michelle Morand. I am a precision cancer medicine educator and advocate, and I'm here today with the cancer guy, Alexander Rolland, precision cancer medicine expert researcher. And he's prepared a PowerPoint for you specific to how to target treatment-resistant mutations, which is a very relevant thing for many cancer patients. A lot of times, cancer treatment seems like it's working initially, and then it stops working. And that is largely because of these resistant mutations. So Alex is going to tell you how to find them and what to do about them. Hello, Alex.
Hi. Yeah, this is the next level of precision oncology. I mean, obviously, when we first started precision oncology, the advent of targeted therapies and tyrosine kinase inhibitors. These are drugs that can go inside of a cell and affect the signaling pathways. Once we discovered these, we thought, wow, this is it. This is a game changer. Unfortunately, what we have discovered since then is that that's not all there is. And we found that many of these targeted therapies have a very limited ability to target mutations. In other words, they'll target only certain specific mutations, maybe 3 or 4, 5, 6 different mutations. And if we develop other mutations, then we can create resistance. So I'm going to go over this in detail. The field of precision oncology, as you know, is based on identifying targetable driving mutations that are present in each patient's unique set of cancer-related genes. And then we can match those with targeted therapies. In order to understand how this works and how common and how critical resistance gene mutations can be for every cancer patient, we need to go over this a little bit and understand exactly what is a mutation. Now, we have covered this before. There's a video link there. But keep in mind that we have, 20 to 25,000 genes, and that's just the start of it. So what is a genetic mutation? Okay, so basically a genetic mutation is a change in the DNA base pairs. So as you can see, we have this nice little diagram from the Cleveland Clinic, and they're showing the different types of mutations. So typically 3 base pairs in a gene encodes for an amino acid, and a gene or a protein is basically a string of amino acids. So you have these 3 DNA base pairs in specific orders, and each 3 combination encodes for or matches to an amino acid. And so if you change one of these base pairs, or you can change 3 in this particular, in slide A, or the top part, you can see there's 3 being deleted, then you're going to be missing an amino acid. Or you could have an insertion where you get an addition of an amino acid and then a substitution. But typically, most mutations are going to affect one base pair, and that's going to change the amino acid. Okay. So you may start with a guanine at this one position, you change a base pair, and all of a sudden you've got an arginine.
Okay.
Okay, so this is going to change the function and the structure of a gene. Often in oncogenes, which are cancer-causing genes, what this does is it causes the gene to stay stuck turned on. And oncogenes are involved in the process of renewing cells, growth, dividing, that sort of thing. And so when they get stuck turned on, you end up with a process where a cell is constantly growing and constantly dividing and creating new cells. So that's what happens when an oncogene gets a mutation. It can become constitutively active.
And that's what tumors are essentially, is these masses of these cells copying themselves.
Exactly.
Should have turned off.
Yeah. But what's really important is understanding the scale of what we're dealing with here. Okay. And a lot of times I hear doctors talking about, oh, well, we tested for mutations in that genes, and we couldn't find any. And when you understand exactly what a gene is, and how many possible combinations of mutations you could have, then you understand that that's not possible. So in order to understand this, let's just do a little bit of math here. So to determine the possible combinations of mutations in a single gene, we need to take the 4 possible base pairs, which is A, T, C, and G. Each one of these stands for an amino acid: adenine, thymine, cytosine, and guanine. And multiply by the power of the length of the gene in base pairs. Okay. And so, genes vary in length. Oncogenes are usually a lot smaller than tumor suppressors. But just as an example, one of the largest human genes is a dystrophin gene, and it has 2.4 million base pairs. So if you want to calculate how many different combinations of mutations could occur in this gene, then what you would have to do is take 4 by the power of 2.4 million. I don't even want to talk about the number that's going to create. But what I will do is I'll talk about a number that we can look at. So let's just say we take 150 base pairs of this dystrophin gene, tiny, tiny fraction of this gene. And we want to calculate how many mutations can occur in 150 base pairs. Then what we would do is we would do 4, which is the amount of different possible base pairs at that position, by the power of 150. And you can see the number that gives you. It's massively huge. This number is significantly larger than all of the atoms based on hydrogen in the visible universe. So not when I say visible, I don't mean what we can see as people. I mean what our technologies can see and what we can predict. And there's a lot of atoms in this universe.
Right. So point is here for those
is the complexity here is ridiculously high.
There are a lot of spots on a gene that can have mutations is the point. And one of my favorite things to remind people is it's not possible for you to not have markers for cancer. It's not possible for you to have cancer without having some mutations. So if you hear that from your doctor, it means they used a very small panel that looked at just maybe a couple of base pairs on a couple of genes.
Yeah, exactly.
To everything that needs to be.
That's it. Yeah. So that's a lot of mutations, you say. This is why spot panels are a complete waste of time. Spot panels are designed to find a mutation that will indicate whether a certain drug will work or not. But they don't consider all of the mutations that could be beneficial and that could be targeted. And more importantly, they don't consider mutations that could prevent that drug from working on that specific mutation.
And that's really what we're here to talk about today, right? Is this
what we call desensitizing mutations. And, I see this all the time. Patients get put on a drug because they have a targetable mutation and they don't respond. And they say, okay, well, there's nothing else for you. When all they needed to do is do a proper DNA test, find out what mutations that patient has, and then use the drugs that target those other mutations.
Yes.
So if you get a tumor DNA sequencing, the message is get a proper one that looks at all the mutations, not a spot panel.
Alex has made a series of videos about genetic testing. That we have a playlist about tumor DNA sequencing on the Cancer Guy channel, so make sure you have a snoop at that.
Yeah. So the example I'm going to use today is with EGFR inhibitors. They're really big in lung cancers. They've been the poster child. I think gefitinib, Iressa, Tarceva was one of the initial precision oncology targeted therapies I learned about way back in many, many years ago, 20 years ago or so. And so they're kind of the poster child of targeted therapies. They're common in a certain type of lung cancer, EGFR positive lung cancer. So we're going to talk about this because there's many different EGFR inhibitors, and I think this is a perfect case example. Patients with EGFR mutated non-small cell lung cancer are often provided with a drug called osimertinib. This is a newer drug, and it works quite well. It's like a 3rd generation EGFR inhibitor. It was designed specifically to work on a mutation called the T790 mutation. And this mutation causes resistance to 1st and 2nd generation EGFR inhibitors. Prior to that, we kind of struggled with this T790M mutation. Now we've got a solution to it, and so this is a go-to drug. However, this drug is actually often being used in the first line and on patients that don't have T790M mutations, based on data that shows that it's a very effective drug. However, we've had patients on this drug for a long time. We're actually one of the first to ever use it. Many, many years ago when it first came out, we used it in clinical trials. We sent patients to clinical trials on us in Seattle. We're excited when this drug came out. However, we're seeing a lot of resistance to this drug. And this is often due to what we call EGFR secondary mutations. So one example of an untargetable EGFR secondary mutation is the EGFR C797S mutation. Basically, this mutation, you have a cysteine at the 797th position, and it's been changed by an S amino acid. And basically what this does is it changes the fundamental structure of the gene, and it changes it at the cysteine residue at the position of 797 of EGFR, and causes it to change its shape. And all of a sudden, osimertinib can now not access its mutations that it normally does, and it can't bind onto the gene because the shape has changed. So, these genes and drugs are like lock and key. And if you change the binding pocket, the shape of the binding pocket, the drug is just not going to work. It's not going to be able to attach to the gene and turn it off. And so that's what this EGFR C797 mutation actually does. So there's no real drugs to target this C79S mutation. And so often patients that have a regular EGFR mutation that's targeted, and the T790M mutation, which osimertinib targets. So osimertinib targets the regular mutations as well as the T790M, but it does not target the C797S mutation. And what happens is when you take osimertinib, if you have this C797S mutation, the osimertinib will prevent the the regular mutated EGFR subtype or subcells from growing, but then you get the subpopulation of C797S cells that are driven by that mutation, and they're resistant, and they're going to grow and take over, and all of a sudden you have complete resistance to treatment.
Yeah.
So, basically there's no treatment options for a patient that wants osimer. Well, there is now. It's actually
there is now.
It's a
This
huge
helps us
market.
understand, though. This is two things become clear. One, from the patient's perspective, why my drug that was working stops working. Now, it doesn't have to be specific to this particular mutation or this drug, but this is why that happens, is you have some sort of resistance mutation that isn't identified and isn't being targeted. But this is also why sometimes doctors on the front lines, these oncologists, think that genetic testing or targeted therapy is not that beneficial, is perhaps they might have tried one of these drugs on a patient, maybe when they first came out, and really just didn't understand all the other factors that got in the way of that working. So
and that's because they're not trained in the actual mechanisms of cancer drugs and genetics, and that's not their field. They got enough to worry about trying to keep a patient healthy. So this is our job. We go into the nitty-gritty of how a mutation affects things and how a drug interacts with that mutation. And that is the most important thing in determining whether someone is going to respond to a drug or not. So once again, no drug for the C79S mutation. So what we do is we look at how the mutation works. And then we come up with another drug that works on that mutation. So drugs are very specific to how they work. They're very specific to the mechanism. So in this particular case, there is a drug that targets a different targeted therapy. It wasn't designed for EGFR mutated cancers. It was designed for ALK, anaplastic lymphoma kinase gene mutated lung cancers, which are kind of a more of a rare form of lung cancer, but they do happen. And so in this particular case, there's a bunch of drugs for ALK mutations, and they work quite well for ALK mutations.
Okay.
So in this particular study, what the scientists did is they did a computational simulation to find out if there was any drugs that would fit the binding pocket, this new binding pocket of the triple mutant EGFR. In other words, this EGFR C797S mutation, how it changed the structure of the gene. They said, okay, well, we're modeling this. Let's just pop it into a computer and see what drugs will actually bind that specific new binding pocket that is created by this mutation. And they found out that an ALK inhibitor did that. And the ALK inhibitor is called brigatinib. Not an expensive drug. It's easy to access. And so what they did was they said, well, great. So brigatinib is actually a solution for this EGFR C797S mutation. And so, we've known this for a little while, for a couple of years now. But what they did in this study is they looked at this particular triplet mutation, where you have the C797S, the T79M, and the regular activating mutation. And so what they did was they took brigatinib, they combined it with cetuximab or panitumumab, which are EGFR monoclonal antibodies often used in colorectal cancers. And they found that these two drugs actually decrease the surface and total EGFR expression when combined with brigatinib. So in this case, they had a case study, and I put the reference here by Chen et al. 2023. And they found in this particular study, a patient with EGFR exon 19 deletion, which osimertinib will target, I believe. And this patient had an EGFR exon 19 deletion and T790M, and then also had this C797 mutation. And the patient had a significant response to single agent brigatinib after progressing on both afatinib, which is an earlier generation EGFR inhibitor, and osimertinib, which is a third generation. So, they gave this patient afatinib. It probably worked for a while on a certain percentage of the cells. And then they gave the person osimertinib. I think they gave actually osimertinib first. And it didn't work. Or worked for a while, not very long, killed a certain percentage of the tumor cells. And then obviously the C797 mutated subtypes actually kind of took over, and they didn't have any treatment options. So in this particular case, this brigatinib, by itself as a single agent worked incredibly well and provided more time for this patient.
Wonderful.
Yeah. So targeting treatment-resistant mutations using drugs based on mechanism is an important new approach to precision oncology. That's what we do. And this is the next level in precision oncology. And, the future's here now. We're able to do this with computer modeling. We're able to do this just often with a peer review search. We're able to say, okay, what drugs will target this resistant mutation this patient has? And once again, every patient's resistant mutations are going to be unique to them. If you look at the possible combination of mutations that can happen in the EGFR gene, it's massive. So this feeds back into, really looking at the mutations in the gene and looking at the drugs and how they target those mutations and making sure you come up with the right combination of mutations.
Right. So there's kind of two key pieces. There's for each individual patient, the need to identify the primary molecular features or drivers of their cancer, as well as this extra bit of the things that might get in the way of certain targeted therapies working. And so that kind of analysis, or the genetic testing or tumor testing required to figure that out, plus the information about the mechanism of how these drugs work.
Right.
That's kind of the key here, I guess.
It's everything. That's everything. And that's why I'm glad I stuck out Biochem 300.
Yeah, because you can understand
It's a horrible course, but that information is
too.
so useful in what we do today.
Yeah.
So let me give you another example of how we use this information. And this is a classic example. We recently had a patient with germ cell ovarian cancer. These are horrible tumors. The patient wasn't really responding to anything the doctor did. The only real treatment for these ones is surgery. I don't know if you know anything about germ cell tumors, but these are the ones that can grow like, hair and, skin and all kinds of weird things. And that's because they're derived from multiple tissues. And so they're really hard to treat. They don't respond well to chemo. In this particular case, the patient was treatment resistant and told they didn't have any options except for one chemo drug that he's going to give them about, I think, a 10, maybe 15% chance of responding. So we sequenced her genome, or her tumor genome, and we found that she had a BRAF mutation. Now, when we looked at this BRAF mutation, we realized it wasn't one of the targetable mutations. So normally in BRAF is a BRAF V600E mutation, and that's targetable by a class of drugs called BRAF inhibitors. And if you have that mutation, then you can take a BRAF inhibitor. Unfortunately, this was a unique mutation. It was called the K499E, and it had a completely different mechanism than the BRAF V600E. So what we did was we looked at the mechanism of how this mutation caused the cancer, and we found that it worked in a unique way. So with the V600 E mutation, it works by, I'm gonna generalize here, so don't quote me on this. But, think of the normal BRAF mutation as getting stuck to its targeted partner and staying turned on. Let's just call it that, okay? When it gets turned on, it can't get turned off. However, in the BRAF V6 or the BRAF K499E mutation, the way it caused cancer and overactivation of this gene is it did something called dimerization. And dimerization is something that, many receptors or many genes do. So dimerization means that you have one piece of the gene, or you have one gene here and one gene here. So you got these two different genes, and they come together, and this gene turns this one on, and this gene turns this one on. So together, they turn each other on. It's called dimerization. And it's a common mechanism in how genes get turned on. Okay. In the V600 gene, it has a mutation that automatically turns itself on. It's self-turning on. Whereas in this process, these two genes come together, one turns one on, they're the same gene, they're both genes, but one turns this one on and the other one turns this one on. Okay. And so we knew that there was a drug called gefitinib that actually worked on dimerization and actually worked that way. And so we got the patient on this gefitinib, and it was a tough sell. I went to the oncologist and I said, hey, listen, this is it. This is how it's going to work based on our modeling. And he says, well, this is ridiculous. You can't use an EGFR drug called gefitinib on a BRAF gene. Even I know that. And I said, let's give it a try. And so he actually gave it a try. And the link to Gail's story here is really something, because we did a lot more than just that. And I won't talk about it now because we're just talking about the initial steps we did with Gail. But I do suggest you watch her video and her interview here. It's an amazing story, really something. Yeah. Anyways, she instantly got a response to this drug. And she was so blown away. The doctor was so blown away. It controlled her tumor. She even went to the Mayo Clinic. And, the Mayo Clinic doctor says, I just don't understand how this is working, but it is. So we're really impressed by this.
Yeah, we're very happy.
Yes.
Yeah.
So, I suggest you look at the story, and here's our final page.
A follow-up for you. I just want to be clear. Alex didn't tell the doctor what to do. Doctors are going to make their own decisions based on the data. So what Alex is trying to say in short form is he provided this doctor with all of the data they needed and all of the backup, and of course spent some time speaking to this doctor to help them to understand the mechanisms that we've just kind of described to you here, so that it could make sense to them to try. Even though they were still quite skeptical, they understood there was a basis for this. I just really want to make that clear, because it is important to understand that oncologists have to understand why something's going to work. They're not just going to do something because somebody tells them to, and I want to make that clear. But what Alex has shared here about the importance of understanding the desensitizing mutations, or just all of the things that can get in the way, even that massive number of all of the different possible mutations that one gene can have. This is why I just want to come back to, if your doctor says you don't have any markers for cancer, that is not possible. All they're telling you is they didn't have access to a very decent test. That's all they're telling you. Do not give up. And of course, if you started on some sort of targeted therapy and it stops working, that is because you have some sort of desensitizing mutation. And there are tests that can identify that. And then you can have, hopefully, an experience like Gail, where that perfect combination to target all of the mutations of your cancer can be found and give you an amazing outcome. If you want to find out about how Alex and his team can help you, we've got some information here about how to book a consultation. Of course, join and subscribe to the YouTube channel. Stay informed. It's the best gift you can give yourself. And I added a link here to an educational program that my team and I have created, and we've dragged Alex into it every Wednesday for a live Zoom. But there's an amazing amount of information here, and it's free. So join and tell everybody you know. And if you're a patient or an advocate, you want to be involved here, because the most current science is going to be shared, and you get a chance to speak to us directly every week about your needs.